I'm going to talk him up a little bit. So he was an adjunct professor at Pacific University, which is in Oregon, USA. He holds professional registration in Canada, and he did so in Washington State, USA. He's had over 50 professional speaking engagements that he's listed to me. There's probably been many, many more of those. He's sat on over 13 advisory panels and was a member of over 13 different professional associations. He was sounded out by movie and TV shows to provide specialist advice. And he's a wonderful human committed to making things a little bit better in this space. So before we let Gerry go, as always in Australia, we pay our respects to the people whose lands we're on today. I'm on Awabakal lands, and we acknowledge and pay our respects to their elders past, present and emerging. Gerry, I'm going to hand it over to you and go quiet for a little bit until we come back with some questions at the end.
Very good. And thank you, Andrew. So doing this podcast forces me to review what I've developed, why I developed it, and my experience in using the C-Rod in clinic. And I'm happy to share that experience with you and my colleagues and anybody else who might be listening. My last podcast was with postconcussionincorporation.com with Michelle Page in the UK. And if you want a little broader perspective of what the C-Rod does, that'd be a good listen to, but I'll be focusing for the next 20 minutes just on some specific things Andrew and I've talked about. So as Andrew mentioned, I'm a graduate of Pacific University College of Optometry in Oregon. My undergraduate studies were in physics and visual science as well. Primary care optometrist, just like many of you. My setting is an office on the 14th floor of a 30-story office tower, and I've been doing this for about 38 years. Recently, my special interest came onto concussion injury and primary care optometry, both the diagnosis and therapy. I was seeking a way for optometrists, as we as optometrists can offer patients help in helping themselves in their journey to recovery. So my interest in visual evoked potentials and oculomotor distress with concussion injury started in around 2014, when the general public and the medicines were becoming more aware of concussion injury and trying to assess how we can best help each other through this process. So I initially looked at visual evoked potentials, which is a way of measuring electronic signals from the eye through to the brain. And although we could track the injury, monitoring the injury was not beneficial really to the patient. I needed to find a way to help people rather than just assessing people. So I went back to my memory and talk about the C-Rod and how it comes along, but I must give first, of course, a disclaimer that I am the inventor of the C-Rod, and therefore in theory, I do have a financial interest in this project. The truth is, I'll be very happy if I even recover my costs. The cost of developing, patenting, trademarking a product like this is extensive. And so if it gives good to others, then I'm satisfied. For my colleagues, good reading reference that I think is very good that covers a lot of what we're going to talk about is Binocular Vision by Shaman and Wick, their 4th edition book. These two fellows put out editions that give good, up-to-date references for binocular vision and binocular vision disorders. So the purpose of our next 20 minutes is for me to explain the C-Rod, to briefly discuss ocular motor skills. And we want to talk about ocular motor skills as they pertain to concussion injury and recovery, reading, and sports, and how people can do 6 eye exercises 5 minutes a day to enhance their ocular motor function. So ocular motor skills, there's basically 3 distinctive yet integrated eye movements that we look at. There's saccadic eye movements, moving our eyes back and forth, fixation, holding a focus on one spot, pursuits or tracking, where we're able to follow a target without losing or breaking up in that target. Ocular motor skills develop between 0 and age 8. They are acuity dependent. And when there's a brain injury, ocular motor function does not break down in isolation of any one of these 3 skills. It's usually 2 or all 3 of the skills, but never in isolation. So as a brief description, saccades can be done in a horizontal plane, vertical plane, or oblique planes. They're tracked as being fast saccades or slow saccades. The voluntary saccadic motions begin in the frontal eye fields. The signals go through to the lateral geniculate nucleus and then to the midbrain. As an observer of patients who are being tested for saccadic function and dysfunction, we look at overshoots and undershoots, fatigue effect, whether the right eye and left eye are functioning equally. We want to see if the response to the signal is slow, or if there's a latency or a lag. With concussion injury, we want to test and train isolated neural pathways to reduce confusion to an already confused brain. And that's part of the process of why I came up with the C-rod. With fixation, of course, we're maintaining fusion. In clinic, we test this with cover tests looking for ESO and exophorias and tropias. We want pursuits to be smooth, accurate, and full, and we want to watch for midline jump. So if we just talk about the C-rod for a moment, the C-rod is a plastic rod, as I'm showing you here. We know that there's standardized norms for saccadic testing. We know that the standardized norm is a space of 20 centimeters, 40 centimeters from the target person. We also know that the maximum lateral gaze range from center to right or left is 19 degrees. And so if a person was to move their eyes beyond 19 degrees, that would initiate head movement. And in vision therapy, we don't want to initiate head movement. We want just eye movement. So by holding a 38 centimeter rod at harm and distance, we work with a maximum range that we're looking at for saccadic eye function without causing head turn. So how I came up with this was, I was in a lab at Pacific University in my second year optometry. We were looking at ocular motor function and dysfunction and training fellow students. And I looked around the room and I saw that some of the students were holding targets at variable distances. So were they at 20 centimeters? Were they at 30? Or were they greater than 40? Were they on plane? Were they off plane? Or were they off plane this way? And all that matters when you're dealing with somebody with a brain injury. You have a confused mind, confused brain, and you're asking it to do more difficult things than you specifically want to train. We want to, when we're training people with brain injury, we don't want to be accidentally off plane and not necessarily target unintended muscle actions, nerves, and nerve pathways. So in my clinical setting, I would typically see a concussion patient perhaps 4 to 8 weeks after their injury when they start to look for help to recover. So I will screen people in the chair by having them hold on to the C-rod at eye level, and I'll ask them to look from one side to the other, counting out loud 1 second at a time. So 1, 2, 3, 4, and I hope to see them get up to 30. When people have a brain injury, they will typically get to 4 or maybe 8 pulses, drop the rod, cradle their head, say, I'm going to be sick, I'm dizzy, and ask me not to proceed. It's absolutely dramatic what the response is. When I'm also doing an in-clinic training and a screening for concussion patients and you do your general workup, always watch for a vertical tropia. It's an easy miss in clinic, and it's a large source of distress for patients as well. So if patients can satisfy me that their lateral slow saccades are not too bad, then I'll ask them to do dynamic near pointed conversions. So looking from one tip to the other, counting out loud, 1, 2, 3, 4, and I'll assess the distress level that they have there as well. And finally, if they're doing well on that, I'll ask them to look back and forth as quick as they can for as long as they can. They don't have to count. But anybody with a concussion will have a very difficult time at doing that. The literature shows us that ocular motor function and dysfunction is common with traumatic brain injury, and it will respond to therapy. Ocular motor distress will recover 4 times faster with therapy than without therapy. So it is my hypothesis that those people who have vision distress with their concussion, and almost everybody does, that as their ocular motor function returns to normal, that they will return to a symptom-free functional lifestyle. And when that happens, you can consider that to be a positive feedback mechanism. So they start out with the C-rod being in distress, and then as they go through the exercises over time, they have less distress, and they're able to function more in the world with less distress. And in order to prove this, that theory, there's a study going on at University of British Columbia in Vancouver right now at arm's reach for me to show whether that is in fact true or not, and to have a published paper on that theory. So as ocular motor skills recover, the symptoms of concussion injury decrease. So the C-rod actually becomes a diagnostic and a therapeutic tool and a feedback tool. So you can diagnose the actions of ocular motor function with a C-rod. You can also use it for the therapy, and then as people regain function, that becomes their feedback tool. People with a concussion are intolerant to doing these things initially, and with time become less distressed while doing 6 exercises. And a well-functioning human being can do these 6 exercises in 5 minutes without distress. Now, if you look through your textbooks and you look at the visual symptoms of somebody with binocular disorders or convergence insufficiency, you'll find about 10 common symptoms. Symptoms including acidopia, headaches, intermittent blur, diplopia, symptoms being worse at the end of the day, inability to concentrate, words move about on a page, decreasing reading comprehension. So those are common to binocular disorders and convergence insufficiency. When you look at the surveys of people with concussion vision symptoms, you find exactly the same list plus a few more options. So the other items include poor balance and coordination, eye strain, blurred vision, inability to read, dizziness, and light sensitivity. So the two are very similar to each other, which is why I believe that training ocular motor dysfunction with a C-rod will help the visual symptoms of somebody with concussion. So let's get back to the C-rod. The C-rod was developed to be a low-cost, portable, easy-to-use vision therapy tool that will detect ocular motor dysfunction, be a therapy tool to enhance ocular motor skills, and provide feedback during the recovery. And the feedback is recorded on day-to-day activities so people can see that they're actually improving in their skill set. Anytime you're helping somebody with a minor traumatic brain injury, they're going to ask you 3 questions. Am I getting better? How do I know I'm getting better? And what can I do to help myself get better? And by using the C-rod, all 3 questions can be answered. I'll jump briefly over to reading development. We know that children learn to read up until grade 4, and after grade 4, they start reading to learn. When, of course, children learn to read, they have to change their gaze from left to right to left to right. They have to maintain fusion, not have a midline break, and have smooth saccades. Children who have ocular motor distress while they're learning to read will complain of headache, they'll avoid reading, they'll have double vision, confusion, and their comprehension level will be lowered. Reading, of course, is a complex brain function that is very energy expensive. And if you think of brain energy as being an energy pie, if a child is spending a lot of energy just trying to maintain focus and function, then the amount of energy available to do concentration and retention is compromised. In sports vision for ocular motor skills, we all know that athletes have better visual skills than non-athletes. We want athletes to have eye movements that are faster, smoother, with better endurance, and no breakdown of binocularity. And the phrase I love to say is that you cannot play the ball until you see the ball. So way back in 1982, when sports vision was being developed, Professor Alan Reichow led a study in which I got to participate in. And what we did is we took photographs of baseball pitchers as they released the ball. So we'd have a slider, a fastball, whatever it might be. We put all these baseball players, and the school had a very good baseball team, into a theater, and we would flash pictures of the pitcher releasing the ball. But we make that flash go faster and faster and faster. And eventually the players could not recognize what was being released. Then we put the players through vision therapy, and part of that was oculomotor training. And eventually they could recognize the release of the pitch sooner. So they were therefore able to determine whether they're going to make the decision to swing the bat or not swing the bat. And the beautiful thing about baseball is that there's batting averages that are recorded. And we were able to show increased batting averages through vision training and partially with oculomotor training. Other sports like golf require something called quiet eye. That is, you can hold fusion in a quiet, relaxed way. And the best way to train quiet eye is to push the system beyond its natural limits so that at the time when it needs to be quiet, it can be. So, Andrew, this might be a good time to show up that little video I sent you. But the C-Rod has 6 eye exercises. So the first one is just a simple fixation. So we want to hold and maintain fixation on the far target for 10 seconds. And that can be done at different angles throughout the visual field. And of course, we want to do near-far dynamic jumps. So I would have people count out loud, looking from target to target, 1 second at a time. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And they would do that for 30 seconds. And as it becomes easier, you increase the demand by moving the target closer to the eyes. We can do pursuit training where we have the person following the tip back and forth. And we want to watch the person that there's no midline jump and no loss of fusion at the center. We've already talked about slow saccades, counting out loud, 1, 2, 3, 4, 5, and on so on. And then fast saccades where people will go back and forth as quick as they can for as long as they can. And of course, we want to record how long they can do that. And if you can, count how many pulses and record that until a point of exhaustion.
So Gerry, we're just playing that video now.
Oh, very good. You can tell me when I should proceed. I suppose I can continue talking while you're watching that. So when you issue a C-Rod in your clinic, you want to set goals and realistic expectations for your patients. Determine, first of all, if the person can perform all 6 tasks. You want to establish and record baseline performance. Be aware of the frustration level and don't push the person beyond their frustration level until they're ready. Always, like in any therapy setting, offer positive reinforcement. Start slow, build within the person's capabilities. Emphasize progress occurs internally within the visual system. We're looking for quality better than quantity. So make sure that you have an auditory feedback loop of counting out loud slowly, 1 second at a time for those exercises that you're required to. So this way, the C-Rod is both an exercise tool and a feedback tool. And accuracy and endurance is more important than speed. And most of all, make sure there's no head movement as you're watching the person. Now, of course, the C-Rod can be used in clinic or it can be used as home therapy. So the pros of having home therapy, of course, is that there's a lower cost to therapy. It's more convenient to the patient, and it may be more practical to just do exercises at home. The downside is, of course, is that you can't measure compliance when the patient's at home. You cannot monitor proper technique, and you cannot measure and assess progress or regression. Clinic-based therapy has the pros of having better oversight. Proper techniques can be reinforced. Training can be tailored to the individual's needs, and verbal feedback yields better results. Always use verbal feedback. The downside of clinic therapy, of course, is cost, convenience. Geography might not allow for it. And what I see oftentimes too is that clinics use a cookbook approach, regardless of their diagnosis. We know that concussion is a very individual condition, and not everybody will respond or recover the same way. And concussion, to my mind and to the minds of many, is a lifelong injury. We just want to get people back to a comfortable lifestyle free of symptoms. Andrew, do you have any questions?
Gerry, that was fantastic. I guess as someone that's a little bit lazy in regards to their own recovery of various issues, sporting or other, how does someone stay motivated to keep training, keep using the C-rod on a regular basis so they can see the improvements?
Well, let's start with concussion, since that's where my passion is. Anyone I've encountered who has a concussion is looking to get better. They are frustrated with their quality of life without getting better. And they can, by recording baseline and recording daily activity, see that they're getting improvement. And when asked, they will say the quality of their life is better, even if they never get back to where they were prior to their head injury. If they can function without light sensitivity, double vision, and chronic headache, that's a win. In terms of athletes are motivated people, and motivated people are always looking for an edge. And in sports vision is commonly overlooked as an essential tool to being a good athlete. We look at nutrition, sleep, exercise, bodybuilding, flexibility, but too many times people overlook vision. And you can't play the ball until you see the ball. Reading, of course, children fall through the crack all the time. And I would love to see a classroom where if you had a classroom of 20 kids, that you had 10 C-rods, and 10 of the children would watch 10 of the children doing the exercises and trade off while the teacher tells them how to do it and what to do. And if they had even 5 minutes a day to do that, that's 10 minutes with 2 children trading off. Imagine how reading capabilities would be enhanced.
Fantastic. So do you think there'll be a time when you see the evidence that their reading capabilities have improved, if that was a thing?
There are many, many studies on the benefits of vision therapy and specific therapies. The literature is full of it. I know that there are many people who want evidence-based results before they'll participate with anything. If you look at the definition of evidence-based, you'll find that it actually initially in 1992 included the subjective opinion of the practitioner based on the needs of the individual that they were working with. And so they now call that evidence-informed rather than evidence-based. And I think that the pendulum is swinging back to where the judgment of the professional is valuable and the needs of the individual are individual. And you also want to have input from the person who's receiving therapy as to what they can or are willing to do. And that's what evidence-informed allows you to do.
Very good point. So a step towards personalized care, which we're all loving. Do you have a favorite recovery story of a person, or can be in the sports environment or outside it, from using the tool?
Actually, one of the most rewarding instances, I had a lady come in and she was obviously searching for help. She'd had an injury, a sporting injury, and had chronic headaches for years and years. And many of these people who never get well continue to search for help and somehow got my name. And I always do a primary eye care examination at first to make sure there's no underlying pathology and look at the total function of the person. And I did find a vertical deviation. And I never see patients after they receive their glasses. I pass off the prescription to my optician. The optician does their work. And on delivery, the optician gets to see the smile on the face. But I asked on this one person if I could see them when they were putting on their glasses to make sure I hadn't made a mistake and that I was on the right track. She put on her glasses and she burst into tears. And I said, "What's wrong?" She says, my headache went away. And it was astounding to me that something so simple with a small vertical deviation managed, that it would give such instant relief. So although that's not really with the C-Rod, that's a very heartwarming experience that I've had. Now, she did use the C-Rod and gained function as well. But ask any clinician if they had kept a diary, how many wonderful stories they'd be able to tell. We all have a book within us in our professional careers. And for me, that's just one chapter.
Brilliant story. I do love them. So we have a lot of people that watch these webinars and they come from a scientific background. So you mentioned a paper that will be is going to be released at some stage, hopefully with lots of good scientific evidence. Do we have a timeline on it?
Regrettably, the grad student who was heading up the research was in a motor vehicle accident, so I can't say when that's going to be happening.
Hopefully their recovery is okay, and we will get to see it at some stage. Gerry, we're very grateful for the time that you spent with us today. Hopefully lots of people will see this and get a chance to devour all the content, go and reference all the things that you've spoken about, particularly those that are new in this space. We've been very lucky to have you, very grateful with your time. So you have entrusted CXDX Connected Diagnostics to be your supplier in Australia. So if people do want to hear more and Gerry isn't available straight away, you can contact me, and you can also reach out to me for trials of the product. So I am that go-to person in Australia, so you'll be able to get that from the CXDX label below, all the details on how to contact me, and of course put you in touch with Gerry and any helpers. So wrapping up today, big thank you, Gerry. The next webinar we have will continue a sports theme. We've got Professor Hugh Dunstan talking about his amino acid depletion and replenishment strategies and product, Innovate, and that'll happen early June. Thank you to all.
Thank you for having me. And if I could just say to my colleagues who are in Australia, you can make a difference. And I know that in primary care, it doesn't often work well to have therapy within some clinics, but having this tool that you can give people to use at home gives you the opportunity to provide therapy to people that might not otherwise get it. And you will help people and you will be of service.
Brilliant. Very well said. Looking forward to talking again, Gerry. Thanks, everyone.
Thank you very much. Keep in touch.